can see those okay? Great. So again, just because of the discussion today, I thought it'd be helpful to talk about screening and when we do that in pregnancy. And if we do have time, we can go into talking about medications for opioid use disorder, but we're going to sort of be building on that theme throughout these echo sessions. So we'll see where we get to today. But as you all know, one of the main reasons that we're talking about this is that mental health conditions by suicide and drug overdose are the leading cause of maternal mortality in our country. And you can see these graphs here. We just see this uptick that's primarily driven by drug overdoses. We know that the majority of these overdoses that are occurring are driven by fentanyl, and most of them are occurring later in the postpartum year. So not in pregnancy or that early postpartum period, but much later, when people are no longer seeing their OB providers. So similarly, in terms of drug overdose, we're seeing increasing rates of opioid use disorder in pregnancy, and we're also seeing increasing rates of cannabis use and other substances as well. So taking a step back and going all the way back to just screening for substance use disorders in pregnant and postpartum individuals, the way that we screen for them is using a validated questionnaire. And one of the best ones that is well validated is the 4Ps. And I'll talk about that in a second. The NIDA Quick Screen and the CRAFT for adolescents are also validated in pregnancy, but the 4Ps is a really great one because it's short. And it's also what's recommended in our South Carolina expert screening tool for pregnant and postpartum individuals. It's already integrated there. What's nice about that tool, that South Carolina expert screening tool, is it also is asking about intimate partner violence. It's asking about tobacco, alcohol use, mood and anxiety as well. So you're sort of getting all of those things in one. The reason why you want to do universal screening, so every single person, is that it's going to help to reduce any biases that you might have in terms of being inconsistent about asking different groups versus others, not asking others. We also know that these screening questionnaires are better than urine drug screens for a whole host of reasons, and I'm going to kind of go through that. One of them being that the detection of specific substances or absence of use is so short on our urine drug screens. They're not really great tests, and so I want to talk about that, the limitations of urine drug screens, and then when to actually use them in practice. So we know that urine drug screens, they don't test for alcohol or tobacco. Those are our two most common substances that are used in pregnancy, and they're actually the most harmful in terms of mom's health and fetal health and newborn health. We know that the drugs that we're testing for in urine drug screens, they metabolize out of people's systems relatively quickly, 2 to 3 days. Marijuana is longer. I'll show you that chart in a second, in just in terms of the time frame. Most urine drug screens, those ones that the initial urine drug screening, which is the yes, no, whether they're the qualitative screen, they are not often testing for a lot of the semi-synthetic or fully synthetic opioids. So prescription opioids, fentanyl, buprenorphine, norbuprenorphine, et cetera. They're not testing for those. So you just may be missing those altogether. There are a ton of false positives. When you use a cutoff score, then you are often missing a lot of tests, and you're also are missing a lot of positives, but you can also inadvertently say that the test is positive because of other medications someone might be taking. So that's really important to watch for. Some other problems with urine drug screens is that most providers don't realize that when they do a qualitative test, meaning it tests positive for a substance qualitatively, that you need to reflexively do a quantitative test so that you actually are measuring the amount of drug that's present or not present. And when we do urine drug screens, they have to be done with informed consent, and patients have the right to refuse those testings. We need to be very careful about mandated reporting and criminalization of substance use in pregnancy, and so we want to keep that in mind. And ACOG, we have the backing of them to say that urine drug screens are never mandatory in pregnancy or postpartum, probably because of all of the reasons that we just talked about right here. So this is a nice table just to give you a sense of the detection of substances in a urine drug screen and the time frame on which they would be present if someone had recently used. And so as you can see, these are really short time frames, really 2 to 3 days. It has to be their most recent use, except if you're using cannabis and you're using it more regularly. So 4 times a week, you are going to get that within 5 to 7 days. You'll test positive. They're a daily user and a heavy user. You're looking more like 15 to 30 days. So more likely to pick it up with urine drug screens for those substances, but mostly not for these other ones. These are some commonly prescribed medications in obstetrics, excuse me, that can cause false positive when you're in drug screens. So I thought I would just put that screen up there for all of you. Take a quick picture just to have that as a reference and just be aware of a lot of the drugs that are commonly being prescribed at this time can easily result in false positive for different substances, amphetamines, benzodiazepines, barbiturates, PCP, opiates, etc., etc. The one that's not up here is fentanyl does actually cross-react with risperidol. It's a second generation antipsychotic that is often prescribed, and so just know that is a relationship as well. You can get false positives for fentanyl with risperidol. So the other thing that is just important to realize is that, as I kind of said before, not all of our opioids are part of our standard urine drug screen. So you have to often order them specifically. Buprenorphine is not, and norbuprenorphine is the one that we want to order to confirm that somebody's actually taking the medication. And that's often not on these standard screens. If you get say outside of pregnancy, you get a positive urine drug screen for amphetamines, you have to send that for a confirmatory test, which is the gas chromatography mass spec. You should also do that for opioids and oxycodone always. But I would say in pregnancy, just because the risks and consequences of having a positive urine drug screen in pregnancy are so high that at any time I had a urine drug screen that would test positive, I would reflexively do a quantitative test. So you want to ask your lab to do that to confirm the presence of the substance and give you the amount of it. When is a urine drug screen actually helpful? And this is the circumstances where we do use this is that somehow the maternal health is impacted. There's an emergency, there's a loss of consciousness, there's impaired or altered mental status. You don't really know what's going on with this person's health and they're not doing well and you need to get that information quickly. That would be a good time to use a urine drug screen. Oftentimes patients will request a urine drug screen, particularly if they're in recovery. They want to demonstrate that they are not using substances for whatever reason. Sometimes they will ask for a urine drug screen. Standard practice outside of pregnancy is when you are starting a medication such as Suboxone for opioid use disorder, you typically get a urine drug screen at that time just to confirm that, in fact, they are using opioids and that maybe just making sure that there are not other substances on board. Our biggest concern are other CNS depressants. In pregnancy, I think you need to sort of weigh the risks and benefits of that. I would not delay care to get a urine drug screen at that time, especially if I've done a really good intake and evaluation of other medications that I might be worried about co-prescribing with buprenorphine, like a benzodiazepine or barbiturate or any other sedative CNS depressant. You also just need to be mindful of when you're testing and that there could potentially be punitive consequences of having a positive urine drug screen at that time. Oftentimes we just, if there needs to be a report to DSS, we want that mom to have as much time in recovery as possible because that report will go very differently for the mom when you first started treatment versus where they are in a few months from then. So just something to consider. If you're suspecting that somebody is not taking their Suboxone or buprenorphine or they're diverting that in some way, and you want to confirm that the patient is taking that medication, then you're going to order a test for norbuprenorphine. Buprenorphine, people can just sort of tamper with their sample and put their the buprenorphine that they're taking, dip that into the sample, and it will be positive for buprenorphine at really high levels if you got a full mass spec on it. But if you want to know if the body is physiologically responding to the drug and they have the drug in their system, then you would test for norbuprenorphine. Okay, so now those are examples of when you would actually do a urine drug screen, and this is how you would obtain one. One is starting with informed consent. Every professional organization recognizes that this is how you should approach this. Ideally, it's written consent, just because of the stakes are a little bit higher in pregnancy, and you want to make sure that everyone's on the same page. If anything is positive, as I said before, send it for confirmatory testing at this time. So If you're going to use a urine drug screen in your practice, you want to have a standardized protocol for doing that. We've seen in a lot of sort of retrospective chart reviews, a lot of biases that are put into place when there is not a standardized protocol for ordering a urine drug screen. And it disproportionately affects low-income birthing people of color, particularly African Americans. And then when you put in a standardized test, you see that bias and discrimination go away. So please, 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 if you are doing urine drug screens in pregnancy or postpartum, have a standardized protocol for doing this. Make sure you're doing an informed consent process. The person understands why you are ordering this test, what you are testing for, and what does it mean if they test positive. And you want to communicate that to the patient. You want to document really clearly all of those things, why you're doing the test, that the person agreed to do the test, and that everyone's on the same page for what it could potentially happen as a result of this test. If you are doing just the yes/no test, is this positive, negative, using the cutoff, as I said before, please do the confirmatory test before doing anything else. If that tests positive, look for cross-reacting medications and even over-the-counter medications. Ask about those as well, because those can create false positives. So pay attention to that before talking to the patient or getting Child Protective Services involved. So I'm going to go ahead and stop there if that is okay with folks, because I just want to see if there's any questions or